So that shifts us to our next speaker, David Vitale, who's at Cincinnati Children's Hospital. He's an assistant professor there and is a uniquely trained individual who's both a pediatric gastroenterologist as well as trained in interventional endoscopy, which is an area that, again, is really understudied in the pediatric population. So he's going to teach us tonight about the applications of endoscopy in patients with pediatric pancreatitis. So thanks, David. I'm going to let you kick it over to you now.
Great. So thank you so much, Dr. Cote. Great job, Dr. Gadam. Very good talk, and really appreciate the organizers for giving me permission to speak to you tonight. So we're going to talk a little bit about endoscopic applications to pediatric pancreatitis and try to cover quite a broad spectrum of topics in a short period of time here. So I don't have any financial disclosures. So we're going to try to go through indications, diagnosis, and therapeutic utilization of EUS, review risks and limitations of that. I'll also touch briefly on utilization of direct endoscopic pancreatic function testing in children, and then talk a little bit about the indication and therapeutics of ERCP in children, along with the risks and limitations. So this was a study published by our National Society in 2020, looking at roles of EUS and ERCP and chronic pancreatitis in children. And to be frank, we don't have a lot of data in children, and this is an expert opinion paper, but we're able to access just some of the data that's out there and come up with some guidelines. So from a standpoint of pancreatic EUS indications, from a diagnostic standpoint, I think many of these mimic the adult world, both suspected cholelithiasis and choledochal lithiasis, acute recurrent or chronic pancreatitis of uncertain etiology, cystic lesions, suspected autoimmune pancreatitis, Divisum, and also, more rarely in children, pancreatic mass lesions. Also, from a therapeutic standpoint, symptomatic walled-off necrosis or pseudocysts, and then we can also do celiac plexus or biliary pancreatic rendezvous when needed. So this is interesting. This is from 2018, a study looking at a comprehensive review of the literature. And so they went back to 1993 and found 19 publications on pediatric endoscopic ultrasound encompassing 630 procedures, which showed low complication rate, but obviously not very robust data. I think in the last 2 to 3 years, there have been some more studies published, but clearly this is really understudied. From a safety perspective, this is adult data here. Perforation rate is really the same as upper endoscopy. When we're looking at diagnostic EUS, pancreatitis is fairly low risk when you biopsy the pancreas, low risk of bleeding. From a therapeutic standpoint, obviously that risk increases. If you're dealing with luminopose and metal stents, et cetera, you're gonna have a higher risk of bleeding, infection, a higher perforation rate. And obviously there's some cases which are failures too, and you're not able to accomplish what you set out to do. So this is going back to that guideline that was published about the role of pediatric EUS in chronic pancreatitis. And typically the recommendation is that abdominal pain without any suggestive pancreatic pathology, really EUS is not recommended in that subgroup. We want these procedures to be done by appropriately trained advanced endoscopists, hopefully with some experience in pediatrics. The standard equipment that we use is okay for patients greater than 15 kilograms, but otherwise we have to use some alternative equipment. So either through the scope probes or endobronchial EBUS scopes for smaller children. The adult-based chronic pancreatitis criteria, Rosemont and conventional criteria, can really only be used as support and guide interpretation. It's tough to interpret those in the setting of pediatric patients when these are really adult-based criteria. Contrast enhanced, elastography, EUS, both really need further investigation before prime time in children. And then watchful waiting for fluid collections, peripancreatic fluid such as pseudocysts or walled-off necrosis, watchful waiting is really recommended. And then when intervention is required, EUS is preferred to surgical or open interventions. And for diagnosis of chronic pancreatitis, it's a quite safe procedure in children. And then EUS risks are increased when interventions are performed. So just to give you an idea here, this is a 16-year-old with a completely normal pancreas, a different indication than pancreatitis for the EUS, but you see this homogeneous tissue here. We're looking for any hyperechogenic stranding, any lobularity, and really this looks very normal. The duct is normal in size. and this 16-year-old. This is a patient now, 15-year-old, who I saw had several episodes of recurrent pancreatitis, persistent abdominal pain afterwards, and you'll see some lobularity come into view, some mild hyperechogenic stranding, which you won't see on the video here, is some hyperechogenic duct margins as well. So this really falls in that category of indeterminate by the Rosemont criteria for whether this encompasses chronic pancreatitis. So some of those patients we may call them, say, well, they're in the indeterminate category, but perhaps this is early chronic pancreatitis, or perhaps we give a little more thought to the fact that their pain could be related to their pancreas. So fluid collections, much like in adults, the mainstay of therapy in children is observation. Even large pseudocysts and walled-off necrosis resolve with time. And if the patients are not too symptomatic, we can watch them on oral or nasojejunal feeding, or even nasogastric feeding if they're tolerating it. When do we drain? If they're not tolerating enteral feeds or they have significant symptoms. And what if drainage is required? We typically recommend EUS approach when it's available at whatever institution, or a transfer to a higher level of care where that's available. They have lower complication rates, length of stay is decreased. And then if necrosectomy is required, we typically would recommend endoscopic approach to that. So this is a 9-year-old with a genetic causes pancreatitis, PRSS1 mutation. You can see here a body and tail are largely replaced by necrotic with this walled-off necrosis. This patient went on to have a lumen-opposing metal stent placed, and we discharged him home on nasojejunal feeds, which he wasn't tolerating prior due to his walled-off necrosis. So about 2 weeks later, he came back with some new fevers, and this is the 2-week follow-up CT here. So you see the lumen-opposing metal stent. We've got a double pigtail plastic stent within that, which I always put in to prevent that posterior wall from collapsing onto the axios and growing in. There was some debris within the lumen of that stent on this CT. And so took him subsequently for a necrosectomy, which we'll see in a minute. But overall, endoscopic drainage is really successful. If you look at the adult literature, about 90% technically successful, about 10 to 15% of patients have a recurrence. The largest pediatric study we have was of 32 children with walled-off necrosis that underwent EUS guided drainage with only 5 recurrences. And oftentimes that walled-off necrosis really resolves with time after the index procedure. And if the patient's worsening clinically, consider for serial endoscopic necrosectomy. So this patient, our 9-year-old, did end up undergoing necrosectomy. So you'll see here in a moment, we look within the lumen-opposing metal stent, and it's clogged. There's some drainage, maybe even a little pustular drainage that came out. We used a rat tooth forceps to debride some of this. And, after working for about 20 minutes or so, we were able to get a nice size chunk here and pull out a lot of necrotic debris from within that lumen of the stent. Subsequently, we'll usually go in and flush this with dilute hydrogen peroxide to try to break down some of that necrosis. And in this case, it was an extensive necrosectomy that was needed for this patient. Really, one time unclogging the stent and did a little further debridement within the walled-off necrosis cavity here, and placed a double lumen pigtail stent back within the lumen opposing stent, and came back about a week later, which you'll see here in just a moment. And as 1 week later, much nicer, some granulation tissue there, we were able to take the lumen opposing metal stent out, place a double pigtail stent, and the patient did extremely well. And it's about almost a year later now, and he's doing really well clinically. So here's a challenge that we have, with some of our patients. This is a 2-year-old who came also PRSS1 mutation, body and tail of pancreas replaced with a walled-off necrosis. And this was actually communicating with a pleural effusion. He had been in an outside hospital for quite a while on TPN, and was still having communication of this walled-off necrosis with a pleural effusion and high chest tube output. So they sent him over to our hospital to see what we may be able to do. And in this case, we actually used our interventional radiology colleagues and had them provide external guidance via ultrasound to get a 19-gauge needle into this with a forward viewing scope, because the child was too small for any sort of interventional EUS scope, and get a wire through here. and then we're able to put a couple of double pigtail stents. And this patient did really well. About 3 weeks ago, I took these stents out, and we'd done the index procedure about 7-8 months ago. So he's doing very well. So what about acute recurrent pancreatitis? This is EUS in children with acute recurrent pancreatitis, published in 2018, looked at 32 children. MRCP was normal in 28 of those, but the EUS diagnosed chronic pancreatitis in 10, according to the Rosemont criteria, and found biliary sludge in one patient. So fairly sensitive compared to MRCP. Another study looking at idiopathic acute pancreatitis and ARP was prospective and found that EUS was better than transabdominal ultrasound to detect risk factors such as microlithiasis, and also to detect chronic pancreatitis. So this is another case, 15-year-old that I saw with severe episodic epigastric abdominal pain. Was going on for every 2 weeks for about 2 months. She'd had a pretty extensive prior normal workup. So she had MRCP, a couple of transabdominal ultrasounds, a HIDA scan, lab work, which was all normal. She presented again with pain to the emergency department, and this time was found to have elevated LFTs and lipase. And her repeat transabdominal ultrasound at that time was pretty unremarkable. The pancreas wasn't able to be visualized because of overlying bile gas. She had a normal common bile duct and no cholelithiasis. So we went to EUS for her. And you'll see initially here, we're highlighting the common bile duct, which appeared very normal. And then we were able to see this small 5 millimeter shadowing stone, maybe more like 3-4 millimeter shadowing stone there within the gallbladder that was missed on all the prior ultrasounds and imaging. So what about autoimmune pancreatitis? This comes up fairly frequently for us, and this is a consensus from our national study group, international study group. You know, to be honest, there's not much data out there from a pediatric standpoint. And the recommendations in this guideline note that the diagnosis should ideally be confirmed with a biopsy. EUS guided pancreatic biopsy is the optimal method to obtain tissue, although they acknowledge that sometimes adequate tissue is really difficult to find, and then also to obtain, and then also the results are difficult to interpret. And papillary biopsy, the sensitivity is quite poor. So really, I think the jury is out on this. Oftentimes I have a very in-depth conversation with the families about risks and benefits of biopsy versus empiric treatment with steroids. And we base some of the decision-making on how convinced we are on the imaging that the patient has already had. So we'll touch very briefly here on exocrine pancreatic insufficiency from a standpoint of endoscopy and pediatric pancreatitis. This is reduction or deficiency of exocrine pancreatic enzyme activity and leading to maldigestion and malabsorption. So indirect measures, we know about fecal elastase, et cetera, that measure consequences of pancreatic insufficiency. And then also direct pancreatic function testing, which are, you know, there are several different methods to do this, but they all involve a stimulation of the pancreas, and duodenal fluid is then collected and analyzed to look for the secretory content, and that confirms exocrine pancreatic insufficiency. So this is our protocol at Cincinnati Children's, which I won't go into depth about, but you know, feel free to copy this slide or reach out to us at any time to get more details about this protocol we use. What about ERCP for pancreatitis in children? So it is the gold standard for pancreatic duct imaging. We really try to focus on therapeutic interventions rather than diagnosis. And there's not really any size or age limitations. And we do, you know, essentially newborn children sometimes with the smaller pediatric duodenoscope we have, you know, down to less than 4 kilograms. And we can also do ERCP for children with altered surgical anatomy. And there is some a little bit more robust data on ERCP in pediatrics that it's safe and effective in pediatric patients for pancreatitis. So this is going back to the guideline that was recently published in 2020. Again, if there's abdominal pain without suggestive pancreatic pathology, use of ERCP is discouraged. We want to use appropriately trained endoscopists. The standard equipment in ERCP can be used in patients more than 10 kilograms. Otherwise, we require specialized equipment, and that encompasses usually our pediatric duodenoscope, which is about 6.5 millimeters with a 2.2 millimeter working channel, which is a little limited in what you can do, but for some indications, we can use it. We want to confine this to situations where endotherapy is necessary, exception being perhaps pancreatic trauma where diagnosis may be needed. It's useful in the management of pediatric pancreatic duct strictures and stones. And then when EUS is suboptimal or impossible, consider ERCP for the pancreatic fluid collections. So really the limitations, it can be pretty technically difficult and complex in small children, specifically quite small children where your angle is difficult with the ampulla and the size of the duodenal lumen. And you can be technically successful for these patients, but then again, fail to adequately alleviate their clinical symptoms. Post-ERCP pancreatitis in pediatrics, about rates reported between 3 and 11%, fairly equivalent to adults, perforation, bleeding, and infection as well. This is looking at a couple of pediatric pancreatitis cohorts, and chronic pancreatitis for ERCP is the indication in up to about 26% of ERCPs, depending on where you're looking and what center. Our cohort of children in the INSPIRE group with ARP and CP, 65% of those with chronic pancreatitis have undergone at least one ERCP. So this is a study from a few years ago looking at pancreatic duct stenting, 72 children, 223 pancreatic duct stents, and they reported a very high success rate with low adverse events in that group. So here's an example, a 6-year-old with chronic pancreatitis and a pancreatic duct stricture, which we treated. You can see the stricture here within the head of the pancreas with upstream dilation, and we dilated this, placed a stent, and after serial stenting for about 6 months, this patient did quite well. We may need endotherapy sometimes for even acute pancreatitis if there's stones or stricture in the acute setting, if not improving with conservative therapy. So this is a 15-year-old with acute on chronic pancreatitis. When we went down to do the ERCP, after some imaging, it showed us suspicion for pancreatic duct stones. You can see there that there is a stone right at the ampulla, which popped out right at the time of cannulation. And then after a sphincterotomy and further sweeps, we took out some larger stones as well. So this is courtesy of my interventional endoscopy colleague, Dr. Tom Lin, a patient who underwent a pediatric patient who underwent trauma and ended up with a pancreatic duct leak, and subsequently placed a stent. And this is an occlusion pancreatogram after indwelling stent for a while, and the patient did extremely well here without any further leak. So Pancreas Divisum, we see plenty of that in pediatrics as well. That's approximately 7% of the general population in a large pediatric cohort, about 15% prevalence. And minor papilla sphincterotomy, this was in fact a group, a study that came out of our institution, a group of patients from our institution, and we found good response in pediatric patients. About 2/3 of them improved with their symptoms. But it's really important to note, up to 70% of those patients with Pancreas Divisum and recurrent pancreatitis or chronic pancreatitis had genetic cofactors, which is quite a high number. So this is from a congenital standpoint, one of the things we sometimes see as well and treat are choledochal cysts. So this is the one type of choledochal cyst, type 3 or choledococele, that can be treated endoscopically. And so you'll see endoscopic ultrasound images here first, looking at the cysts in the common bile duct. And here's an endoscopic image as we're starting the ERCP. And you'll see a fluoroscopy image here in a moment, outlining that cyst, which is actually quite a bit smaller than some of them that we see. And here we're doing sphincterotomy or cystostomy, opening the cyst. And we'll see a pretty good rush of bile coming down along with contrast here in a moment. And it's really important with these that we biopsy the lining of the cyst. So you'll see us come in and biopsy the lining, because the lining can either be intestinal epithelium or biliary. And if it's biliary, there's still that theoretical risk of cholangiocarcinoma in these patients. And those that have been treated endoscopically, especially at an early age, there's not really any good or robust data out there to tell us how to follow those patients. So those with biliary epithelium, we follow quite closely with serial imaging. And I think the jury is still out on how those patients will do after endoscopic treatment and in the long term. So post-ERCP pancreatitis in pediatrics is actually, there's several studies on this, mostly from Dave Trendle at UT Southwestern and with his collaborative group of several centers looking at ERCP and pediatrics. So risk factors generally are pancreatic duct cannulation and injection. Chronic pancreatitis is typically protective. And in one study by Dr. Trendle, the prophylactic stent placement in pediatrics actually increased rates of post-ERCP pancreatitis, even in high-risk subgroups. They also did a feasibility study with a slight decreased risk of IVI with administration of IV ibuprofen. And then also recently out of Denver, Jake Mark and his team there looked at retrospective studies showing decreased risk of post-ERCP pancreatitis with IV ketorolac. So we all know about duodenoscope bacterial transmission. Infection risk exists. There's no reported pediatric outbreaks, but obviously trials ongoing, and with recent FDA recommendations, a lot of the pediatric institutions are trialing these scopes. The opportunity for single-use pediatric-sized scopes probably exists and maybe is a little bit more feasible with some of these single-use duodenoscopes. So it'll be interesting to see what comes from some of those single-use scopes. So in summary, EUS in children is expanding. It allows for a lesser invasive approach for diagnosing and treating pancreatic disease, including chronic pancreatitis. Pancreatic function testing is safe and effective to diagnose EPI in children. And ERCP can be safely and effectively done in children to treat various pancreas disorders, including chronic pancreatitis and complications from pancreatitis as well. What about the future? There's plenty of pediatric training opportunities that are now increasing, and more of us are training to be interventional endoscopists. Appropriate size endoscopes and accessories are really necessary, and we have a small number of scopes and accessories we can use now, but really needs to increase. And there's plenty of research opportunities. So thank you again for the opportunity to talk here, and I'll take any questions. Thank you.
Thank you, David. That was fantastic. So a question from the audience is when do you move to endoscopic ultrasound? And I'll add ERCP to that actually. In patients with acute recurrent pancreatitis, is there a threshold number of episodes? Does there have to be symptoms between episodes? You know, at what point do you move to an endoscopic approach in diagnosis and potentially treatment in this group?
Yeah, that's a great question. So I think, you know, one thing that I do is I always take the opportunity in someone that's had more than a few episodes, if we're going to be doing an upper endoscopy for something else. So if, you know, we're trying to rule out celiac disease, or we're going in and taking a look for upper endoscopy just from a diagnostic standpoint, if they've had more than a few episodes of pancreatitis, we'll oftentimes take that opportunity to do an endoscopic ultrasound, which doesn't add much from a risk standpoint, to be able to look at the pancreas and get a baseline study. Other times, if the patient isn't indicated to undergo a procedure for a different reason, I'll usually approach that on a case-by-case basis, where if the patient is having some sort of symptoms in between episodes or some sort of question about the etiology of their pancreatitis, then we'll go ahead and pursue that. A lot of times our patients, you know, when we look at our cohorts in pediatrics of chronic pancreatitis patients, about 70% of them have some type of genetic mutation, which oftentimes, you know, can give us that etiology. But there's still that 30% where there may be some other etiology or we just don't know. And those are the patients I think that are really good candidates to have in endoscopic ultrasound, or those patients that are having, you know, persistent symptoms in between episodes.
Great. So in adults, MRCP has had a major impact in terms of our pre-endoscopic evaluation, and in some cases, eliminating the need for an endoscopic evaluation. But in some of my discussions with pediatrician gastroenterologists, my understanding is that maybe the sensitivity of MRCP is not quite as good for some of the ductal or structural pathology that we're looking for in the adult world. Can you comment on that?
Sure. So I think, you know, it depends on a lot of factors. We see sometimes that there may be an MRCP done at a certain institution that uses a different protocol, et cetera, that maybe is not quite as high of a quality as we see from another institution. And so I think that overall, when we do MRCP in pediatric patients, typically we're able to see the duct well, we're able to see the parenchyma well. There are no real direct studies, obviously, comparing EUS to MRCP in children. And I think that would be something that would be really interesting to do. But typically at our institution, once a patient has had a couple episodes of pancreatitis, once they get their second episode, we're going to MRI and MRCP. So most all these patients that we're doing EUS for have that MRI done. And so if there's nothing on the MRI, or we don't have a good idea of what's going on based on the ductal findings there, then we may go to the EUS.
So I was intrigued by your comment about biopsy, which we do on occasion in adults, particularly when we're suspecting autoimmune pancreatitis, which is, I think, more of an adult or at least older children to adult subgroup. But we don't typically do it in the scenarios that, like Dr. Gadam had outlined, where we're seeing some suspicious findings on the pancreas by endoscopic ultrasound, because frankly, the yield of a core biopsy is, generally speaking, inadequate. Can you comment on the yields of core biopsies in children, what we know, and really what scenarios in which you're doing biopsies of the pancreas parenchyma at this point?
Yeah, so the yield is actually quite low. I'd say, probably, and I tell the families, somewhere between 60 to 70% of the time we get meaningful tissue that I feel, we're able to make a reasonable diagnosis or say, yes, this is autoimmune pancreatitis, or no. A big difference between adult and pediatrics is when we're looking at these biopsies and we're looking at imaging, our suspicion for malignancy is very, very low. And so, my threshold to go in biopsy is typically after a very, extensive discussion with the family, where we may be at our wit's end sometimes, where we see some, sort of either focal pancreatitis or finding that looks like sort of suspicious for autoimmune, but not diagnostic based on the imaging. And we've treated them one time with a round of steroids, they got better, and now they're getting worse again, and we're not sure whether they're going to, and they don't respond to a second round of steroids, or they don't respond to certain medication. And those are the times where we go and do this, where we feel that, perhaps we'll be able to get some extra information. But still, that biopsy yield, as you mentioned, is really not great. And I think it's really a case-by-case basis. There's no good data about this. And while we saw that guideline that suggests that it's helpful, I think in reality, the ability to get those biopsies and have meaningful pathology from them is not very high.
Yeah, and then you add, obviously there's some risk. It's not prohibitively high, but when the yield is 50-50, the risk becomes more relevant. We're over our time, but I did want to ask you for a quick comment in children about pancreatic function testing. Could you comment on what your thresholds are for when you are convinced that the results are consistent with exocrine pancreatic insufficiency? And in addition to that, how do you interpret discordant fecal elastase tests with endoscopic PFT? So if you have a normal elastase, for example, but then you do a function test and it's abnormal.
Yeah, so I think from a standpoint of making the diagnosis, we typically look to see two lines of our enzymes down in a couple sample in one sample, or one line that's down in two different samples. So we collect 3 samples typically, and that's where we're looking to see if there's one enzyme that's less than the laboratory reference range. And from a standpoint of the second question about fecal elastase discordance, typically I put more stock into the endoscopic PFTs because I think the direct testing is a much more direct way to test this. We don't have a lot of patients where we have discordance where there's actually normal fecal elastase and abnormal endoscopic testing, but more frequently we see where there's maybe a low fecal elastase, that's slightly lower, between 100 and 200, and then we get normal direct pancreatic function testing. But typically, I put more stock in that function testing than that screening. I sort of look at the fecal assays more as like a screening test.
And so you're not using bicarbonate concentrations like has been described and what's really more commonly used in adults. You're looking at enzyme concentrations, correct?
That's correct. Yep. And we have norms from children, as young as 1 year of age, and those reference norms. It does appear in those studies that we've done that the patients actually have increasing enzymes as they get a little bit older, and we have actually pretty reasonably good data showing that those that 5, 10, 15 minute marks are good indicators with marked differences between patients that have normal pancreatic function versus exocrine insufficiency. And so those are the marks that we use when we collect the fluid.
Great. Well, thanks very much both to you, Dr. Vitale, as well as Dr. Gaddam, and to everyone for joining this evening's final session of 2021 Pancreas Academy. Really great talks, and I greatly appreciate it. There's so much that we need to learn, both in adults and in children and in patients with known or suspected pancreatitis. So every year there'll be more to share on these topics at our annual meeting. So thanks very much, everyone, and we'll wrap it up for tonight. Thank you.